Good morning, good afternoon and good evening. My name is Jane Barratt. I'm the Secretary General of the International Federation on Ageing. We live in unprecedented times, and in civil society we work with and alongside older people. And IFA believes that we must be acting and advocating differently to be really heard above the almost impenetrable cry for action. One of the reasons that IFA decided to have this town hall is to hear about the resilience and courage of older people that you are experiencing and listening to, but also as a forum of exchange of knowledge about some of the urgent and critical issues that older people are experiencing. But finally, and equally important, it's about being points of a connection for each other, because most, if not all of us, are working remotely now. And each and every one of us are experiencing personal challenges in not only working remotely, but with family and COVID. So we thought it would be an important position to bring us together, to also hear from experts, to exchange knowledge, but also to remember the urgent and critical action advocates like IFA and each and every one of you are involved with right at the moment. Before I introduce John, I welcome each and every one of you. There's over 260 people that have registered for this webinar, and that's a real indication that we want to come together as a global community. I've known John for 10 years, John, more, 12 years.
Something like that.
Yeah. I acknowledge young Benjamin, that's with you at the moment. John will tell you what it's like to be parenting Benjamin in a chalet in France in a minute. But we live in our homes now, and so we recognise the familiarity of our homes, and that's the people that we are. John really was a transformative character in the World Health Organization. He's an Aussie like I am, but during his tenure at WHO, he really helped reframe the whole issue of ageing and older people, and so led the development of the first evidence-based report on ageing and health. So it really, set older people and their ability to be valued and valuable in community like no other. The work around functional ability and intrinsic capacity and the interconnection of chronic comorbidities is certainly one of the stakes in the ground that we will need to hold on to. Since leaving WHO, John hasn't stopped thinking and working with colleagues around the world. So he has positions in Beijing, South Australia, the ARC, University of New South Wales, and also in Germany. So John, it's a real privilege to have you with us today, and thank you for making remarks at this very important time in our world.
So thanks a lot, Jane, and thanks to IFA for the opportunity for us all to come together. And I think this is a really important convening of people who otherwise find it hard to stay in touch. Yeah, I'm like many of you, I'm in lockdown here in France. I'm also a caregiver, but ironically not a caregiver for older people. I'm a caregiver for my 5-year-old who's here. I can't promise that I won't get disturbed during my presentation, but I'll do my best. I thought I would start with just a very broad overview to sort of the background to how we've got to this point. Most of you will know what I'm going to say. And then just very briefly identify some critical issues that I think are important. There are many others, and I'm hoping we'll have plenty of time to discuss them and explore them and learn from each of your experience. So as you all know, this outbreak started in China. The coronavirus is highly contagious, and it can cause a range of outcomes from being asymptomatic through to causing death. And it's problematic because it's highly contagious, and it appears that infectivity continues or starts even before people develop symptoms, or is true for people who are asymptomatic. So it becomes very hard to control it. We know that there are risk factors for a poorer outcome. One of those is increasing age, particularly as it's almost an exponential increase as we increase from 60s to over 70 to over 80 and so on. Other risk factors are having multiple chronic conditions, which are more common in older age, and also being male. There are a range of others which we're discovering, and the evidence for all of this is still fairly weak. A lot of it comes from China, where the problem is because we don't know about all the asymptomatic and untested people out there. We don't know the denominator when we look at the fatality rates. And also it's very hard to know the risk factors because we don't know what we're comparing with. So anyway, it has now, as you're all aware, spread from China to other parts of the world. Some parts of the world were able to control it very early. For example, Singapore is a fantastic example of where contact tracing and very rigorous follow-up has managed to keep the caseload down. It did though shift to Italy, which very rapidly became the epicenter of the outbreak, and now has moved across Europe. Spain now has the highest increase in deaths per day, and will very soon, I think, be overtaken by countries like the UK and the US, and I'll speak about that in a moment. The important thing is what we learned from China is you can flatten the peak, and that's why we are all social distancing, because there is very good evidence, not only from this outbreak, but also from other infectious disease, that social distancing can slow the rate of contagion. And that's important because what we've found in China, Italy, and now in Spain is if you can't flatten the peak tends to overload health systems, and in terrible ways, so that people who need intensive care can't get in, people who need ventilators can't get them. And that then poses real questions about how you ration those services and who you provide them to, which I'll talk about in a moment. I mentioned the UK and the US, and as an English speaker, I've been very concerned that in fact some of the slowest responses have been seen in the English-speaking world, where there has almost been a denial and a focus on the economic impacts and so on, rather than a very rapid introduction of social distancing, even though we knew that that was effective. And so I think the UK and the US are really going to see the consequences of that delay over the next few weeks, unfortunately. So key issues. Well, as I said earlier, I think it's really important that we refine how we identify those people who are at most at risk. It's not adequate just to say that as somebody gets older, their risk increases. That age is only a surrogate for a whole range of physiologic changes that are occurring in the individual, which are changing their immune response. And so I think we need to quickly be able to move beyond just using chronological age as a surrogate for that underlying risk. And that's particularly true if we're going to use it in terms of rationing. And I've been reading in a number of places that people are suggesting that as access to ventilators and intensive care becomes restricted, that we should be restricting on people's health state, on their age, and so on. And I think we need to be really looking at the ethics behind this, as well as the physiology, and trying to come up with a very ethical approach where we can reach a consensus on how these services should be split up, because there aren't going to be enough for everybody. So that's the bad news, but we need to tackle that in an ethical way. That then moves on to another pervasive issue, which is not just something we're seeing in during this outbreak, but which I think becomes highlighted in the outbreak, which is ageism. And some of you may have seen the social media jokes such as boomer remover and things like that. I think the risk is here, and I've also heard quite educated people speak about this, that after the crisis is over, there is a risk that younger generations are going to blame over older generations for the economic collapse, which is almost inevitable. And that if we just let the older people die, then we would have been able to survive this in a much better way, and I as an individual would have been better off. And I think we're going to see some very ugly forms of ageism, and we need to be thinking ahead and thinking about how we can counter those messages in effective ways. I think also there has been some guidance released by WHO on institutional long-term care, but in many places, what I see most neglected is home care and social care of people who are not institutionalized. In many places, we hear politicians saying, well, you know, the older people need to just quarantine themselves. Well, I mean, as most of you will know, that's very, very difficult. How does an older person then get the care they need? How do they get the supplies, the food and other things, the essential things which are required for their day-to-day living? And thinking that just telling the person who's delivering it to wash their hands solves the problem. It doesn't, you know, that the things that are being delivered may have been contaminated. That individual may be spreading the infection in other ways than through hand-to-hand contact. And then you have the whole issue of how does an older person who requires physical care, how do they receive that? And then, of course, issues such as isolation. So I think, you know, this is probably something that many of you will want to talk about. The other thing that I think has been neglected and is absolutely could be overwhelming is the issue in low-income countries. We know from the H1N1 outbreak that the vast majority of cases and deaths occurred in low-income countries, and yet we hardly heard about them. And I think in this case, it's going to be the vast majority of deaths occur in low-income countries in older people. And the consequences for those countries and for those individuals are likely to be very dire. And I think we need to be thinking about innovative ways in which we can ensure that their risk is minimized, that the care they receive is appropriate. I think also throughout this, there's the issue of equity. We've already seen in many countries that testing has been more available for rich people than poor people. I'm sure that if you're a homeless person, it's going to be a lot harder to get a ventilator than if you're not. And we need to be thinking about how we tackle these issues in an equitable way. Now, there is some good news. It does seem that very quickly people are starting to come up with some potential innovative solutions. For example, particularly in younger people, one of the things that can lead to fatality is what's called a cytokine storm, where their immune system ramps up to the point that it starts attacking the individual. And there is quite effective treatments for that now that it's been realized that that's a feature of the disease, and so that may minimize some deaths. We are hopeful that a vaccine will come, and I suspect if we look at the experience of Ebola with expedited development, it will be available by the end of the year, which is a long way away, but it's better than nothing. There is evidence that using the immunoglobulin from previously exposed people and injecting that into people who are suffering severe manifestations can help control the disease. And there's also some evidence that's starting to come from Japan that some of the medication that has been used for pancreatic disease is also able to block the entry of the virus through the ACE2, which is part of the renin-angiotensin system, which is one of the vehicles which allows the virus to enter the body. And so it may be that we will find some drugs which can prevent the disease despite exposure. So these things are evolving very quickly. Again, it's quite hard to progress with them as we don't know the full extent of the spread that's already occurred because testing has been so limited, but there is some hope. As a final point, I think that we're caught in the storm at the moment. And when I've been talking with the private sector and with a number of other people working in this field, what I've said to them is I think we need to be also at the same time planning for after. And after is not going to be the same as before. We have to figure out how to invent that after in a way that fosters social cohesion rather than a way that leads to social dislocation and tension. And that is the real risk. And so I think even though we're dealing with practical, very confronting issues today, in the back of our minds, we should also be thinking about how we deal with this in the longer term. So Jane, I'll pass it back to you.
Look, thanks, John, very much. I just want to come back to one of your final comments and link it to Dr. David Nabarro yesterday, who said, you know, after we will be living with the virus and we must live with it with dignity, with authenticity, and with, the word escapes me, I will tell you.
Honesty.
That's it. Thank you. That was Mary, I think. But dignity, honesty, and authenticity. And that then links to what you just said, John, which is, you know, it's about cohesion versus dislocation and tension. And I think in this time of such acute stress and distress, you know, it's a time where civil society can really think and act together as well. So thank you. We are going to open the floor up for questions. I mean, John has generously said he would accept questions. So, and also, if there are any comments about good practice that you've, you know, have experienced and know about, and perhaps also some of the lessons that have been learned. We've got 45 minutes, so it could be a mixture of those. And Andra will adeptly, I think, manage that. But John, there are a couple of questions that have already come in, so I will kick off. Joseph Batak said, how can post-COVID be a world that brings happiness to seniors and the elderly? It's a great question.
Yeah, it is a good question. You know, I was heartened so I said I'm in lockdown here in France. And my first trip to the supermarket, I didn't know what to expect. But when I got there, there was a queue. Everybody was being spaced 1.5 meters apart with staff from the supermarket in masks and gloves, making sure that was occurring. When we went in, we all went in in groups of 5, so it wasn't overloaded. And there was an incredible spirit amongst everybody in that queue that we're all in this together. And I think that is the key, is somehow we have to get people to understand we're all in this together. And it's not about different generations. And this is part of the reason I worry about this risk assessment on the basis of chronological age, that we keep reinforcing that there's something strange about being an older person, something different. And I think we should be instead looking at the multimorbidities and the other issues which are really the driver of that risk. So in terms of moving forward, I think we ourselves also need to be careful that on the one hand, we protect the rights and ensure that older people receive the care and support that they require, but we need to also be doing it in a way that reinforces social cohesion and doesn't reinforce that idea of a difference. Otherwise, I don't know. I'm sure that some of the listeners have some great examples of things where people are working together, and there are some fantastic things like the 500,000 people in the UK who volunteered to provide care. You know, we have the seeds of a really cohesive, wonderful society after the event. We just have to nurture them.
Thanks, John. I'm going to get Andra to unmute Roni Schenker, because Roni has got a statement, and I think it's an important one. So, Roni, would you just like to speak to that?
Yes, I'm worried about the consequences of the COVID-19 after the pandemic is gone for a while. What will happen to those older adults who are not necessarily at risk today, but due to the social isolation and the limitation in their life space and decrease of motivation and self-efficacy, etc., will have a functional decline and decline in intrinsic capacity as well. And I think we should be very proactive in tackling this issue today as we shall confront a huge gap in our ability to rehabilitate those people after the pandemic is over.
And Rona, you're from Israel, so that
I'm
provides
from
context.
Israel. I'm from Joint Eshel, which is a civil society organization for older adults, and I'm a PhD in occupational therapy.
Okay. John, any comment?
Yeah, okay. No, I totally agree. You know, and personally, I found I have a lot of space and I have high intrinsic capacity. 3 weeks ago, I was incredibly fit, very active. In the last 3 weeks, I've done nothing. So what it means for older people in a much smaller space and without probably the same motivation that I had is, I think the consequences can be very real. So it would be nice if people out there start thinking about ways where we can be not just encouraging older people to remain active, but we give them the means to make that an easy choice.
Okay, thank you very much. Kathleen, you're living in Australia. So can you, and you've got a lot of experience in this field and age-friendly cities, could you say something about what's going on in your local environment?
Thanks, Jane. Australia has been proactive in the simple message of maintaining social distance, of only going outside if it's urgent, and really giving people questions to ask themselves about how they should be behaving in a time of COVID-19, rather than strict top-down law, which is there, but there's this encouragement to be asking ourselves, is this something that's essential to do? And we're also, our numbers are still quite reasonably low, and thankfully our death rate is still quite low. And we're very aware of the conversations and the experiences that have come out of Italy and increasingly of the UK. We're an English-speaking country predominantly, but so there's been a lot of discussion about that experience of the ICU physicians in Italy having to make those decisions about ventilators. What's been challenging, one of the things that's been challenging is the New South Wales government has set up an ethics task force to work alongside the ICU physicians to take some of that burden of choice. But one of the things they've put in their algorithms is something they're calling long-term benefits. And so I'm interested to hear people's views about how we can step forward and, as John rightly says, maintain an intergenerational solidarity while questioning what does a long-term benefit of one person on a ventilator versus another, without recourse to age or without recourse to earning capacity or some of those other measures. But how do we speak about the value that someone brings in non-GDP terms, someone's capacity to live a good life, no matter how many years that life is, that as a part of an algorithm, it's really concerning for those of us working in the age-friendly space. So I'd be interested in people's opinions, certainly John's view on that.
Okay, thank you. John, would you like to respond?
Yeah, no, I agree. And actually, I'd just like to acknowledge, I do think the Australian government has done a really good job up to date. I think, this is such a hard issue, because when it comes down to it, there's a part of me that believes what we've been fighting for the last however many years, which is we all have equal rights no matter what age we have. But on the other hand, if you do think about it from society's perspective, and you think that there's not enough ventilators to go around, and we're going to have to allow some people to die that otherwise wouldn't die, how do we choose who they are? I think I would, in the extreme, say that a 5-year-old, my son, had a greater right to that ventilator than I do, or than my mother, which would be a terrible thing. But, I think that's the way that society tends to think, and personally, I can see that side of it. I don't know where the balance lies, though, where it's not just a automatic stereotyping older person, anyone over 60 doesn't get a ventilator. I mean, I don't know. Maybe other people have got better ideas.
So there's going to be lots of questions come in, and I'd like us to actually put them in the chat box, because this is going to be an ongoing conversation. So I want us to, our conversation to continue rather than just, you know, stop here. So if the topic doesn't get discussed, please don't think it's not going to, it's going to be forgotten. Walter Wittich, I think you're from Canada, Walter, aren't you? So you talked about isolation. Could you sort of speak to the question that you raised in the chat box?
Good morning from Montreal. As a researcher who works mostly with people over the age of 80, my lab right now is frozen in time. I cannot contact anybody or visit or do any data collection. And so many of the reflections about social isolation in the context of my research have tried to look at technology as a solution. And we've encountered interesting barriers in terms of how familiar people actually are with what we as a group right now are doing. You may have personal experience with this in terms of your parents or your grandparents, that the technological savvy is not the same. And so there's an interesting sort of generational breaking point at which we have the possibility of reaching out and communicating, but not the facility locally for people to actually connect or be technologically savvy to connect to Zoom, to Skype, to whatever other kind of way to reach out. And so this is going to be very interesting, that there may be some generational differences within the generation of older adults, depending on their relationship with technology.
Thank you very much, Walter. I've just got a number of people that have noted that they want to speak. So Margaret Gillis, Canada.
Hello, thank you, Jane. I think John has raised a couple of very good points. One, just the incredible ageism that we've seen. And if we even use the example of the boomer remover, if that was any other group, there would be incredible outrage, not just from groups such as ourselves. I think it's put square into our view the need for a convention on the rights of older persons. We need to get the message out about the evils of ageism. And I think we have an opportunity, given John's comments about what we do post-pandemic, to really think about how we can all work together to make that happen. So I think one of the things I'm going to call on all of us is to think about how we can really put the push on for that, and to really raise the awareness about the impact of ageism and human rights violations.
Thanks, Margaret.
Thank you.
I'm going to just put Amal on the spot. Amal, would you like to make any comment about, you know, the impact of COVID and the discussions around conventions? And I know that you're tied because you're from the UN, but perhaps it's not work hours yet. Are you able to respond?
Yeah, hi, thanks, Jane. Good morning, everyone, and thank you so much for holding this webinar. I think it's really important. Over the past 2 weeks, I think I've developed high blood pressure arguing with everyone at the UN here in New York, and trying to bring the voices and concerns of older people and push it upwards in our system. You know, we have the informal interagency group on aging, which has 18 members, and at the working level, everybody has been amazing, pushing, you know, for older people in this context of COVID-19. But it's so hard to get that message upwards to the seniors in, at the UN. And I'm saying this clearly because this year with the UN, you know, the approach of the Secretary General is self-reflection. And this is part of the reflection that we're doing. We would like to see senior UN really understand what's going on with older persons and refer to them and accordingly. I mean, you see with the Secretary General messages, when they do make reference to older people, they're still using the term elderly. And we've several times sent them the GA resolution that says, please, you know, stop doing that. And it's hard to get that message through. And that's just in-house. And this is why the role of civil society organizations and national human rights institutions is key. We need your help. We need you guys to write to the Secretary General, to the heads of agencies, and the messages that you say, you know them well because you're the experts, you deal with older people. It's a no-brainer to you. But it's not to those individuals who, by the way, now we're back to this, social groups competing with each other. Who needs this more? Persons with disabilities, young people, indigenous people, and everybody's busy advocating. So this is a moment where organizations representing older persons should work, the hardest and be the loudest and keep sending out messages and reaching out to affect this. And I know I see that my dear friend and colleague Bethany is on the call as well, and she and I experienced this together with the Secretary General COVID-19 humanitarian response plan that was out, how hard we've worked behind the scenes to make sure that older people were identified explicitly as a group in their own right, and weren't too successful doing this, despite a lot of support from a lot of different UN agencies at the working level as we are. And I understand that Health Age has done amazing work with Human Rights Watch to reach out to OCHA directly and cause a little dent there. This whole conversation for me brings it back to a human rights conversation. I mean, this is literally why member states should consider the need for a legally binding convention. And, going back to MIPA, the Madrid Plan of Action, they flagged this. I mean, member states know this. Years ago, I went back to the MIPA text and I saw in it, there was some language about how there's age-based discrimination in the provision of services when it comes to treatment, and how it's perceived that younger people, there's less value in treating older people when it compares to younger people. That's spelled out there. And that was like how many years ago now? And look what's happening, and the sad, heartbreaking examples that we've seen in developed countries, in nursing homes where older people were left to die on their own. I mean, it's horrific in this day and time that this happens. And this is the moment to pick up on what's happening now and to really push for that. You all know that the open-ended working group on strengthening and the rights of older persons has been postponed. Given what's happening, and this is just my personal feel, so please don't take this as information, it's just my personal feel on this, that although it's been postponed, I doubt that it will take place later this year. It might as a shortened version, but I doubt it. So I think there's time, and I love how John says we need to anticipate what's coming out, such as, I think this pandemic is going to be an outbreak of ageism globally. And just to prepare for that for next year, what is it that we want to do? And we have access to the Bureau, we have access to the chair. So if you guys get together and think and come up with ideas, you could reach out to them directly, or us will be more than happy to also support and connect you with the chair of the open-ended working group to share your concerns and what is it that you want to do about it. At DESA, we have just like the small issue briefs that we've been preparing. The last one was on older people in humanitarian emergencies. We're doing one that will come out, I think, next week on COVID-19 and older persons. And we think this is a defining moment for informed, inclusive, and targeted response. So we will share that widely. It doesn't cover everything, but at least it gives a story, a narrative
Thank you.
that one can use.
Thanks, Amal. And Amal has given us the opportunity. There is a channel there for civil society to give voice and action. And IFA will send that UN DESA report out to all of the people on the call, Amal. So thank you.
Jane, could I just say something?
Yes,
because
sure.
I mean, I totally agree with everything that Amal was saying. And, you know, you were talking about David Nabarro before, and a few days ago, Dr. Tedros said some, what I found were rather patronizing words about older people. Lip service isn't good enough. You know, like these organizations, my old organization, the World Health Organization in particular, need to be providing concrete technical guidance on how to address these issues which we're talking about. We can't just say, we value older people and yes, they'll be included in our thinking. No, it's not that. Older people have specific needs. They're the people who are going to be impacted most by this outbreak. And we need to have clear guidance on how they can get the care and support they need to live a life of dignity. And they're not doing it. WHO has released one document, as I said, on institutional care. There's so much else which we can be doing to make the life of older people all around the world much easier, but we actually need to take concrete action and move beyond lip service.
And I think the word "we," I think it's a good one, John. It's we, you know, it's the collective. And, you know, I was certainly critical of WHO and have been of the UN at IFA. And at the end of the day, this is bigger than the WHO and bigger than the UN. This is the collective humanity, and it will be the defining moment of humanity. So I think it's about, you know, getting our ducks in order as well, to be prepared to stand up and fight. So there are three people, Mike Runge, Bethany Brown, Mike Hoden, and John. Before I go to Mike, I just want to put in your parking lot to talk about is violence. Domestic violence, elder abuse, you know, we are seeing, hearing, thinking, feeling. It's happening. A few days ago, anecdotally, I was told that staff have left some nursing homes because they're fearful of their own well-being. And so I just want you to think about that, and I'll move on to Mike Runge from South Australia. Thank you.
Thanks, IFA, very much for organising this. Well done. My question's really to John, and it's a question about the opportunities that older people might have at the moment to be making a significant contribution to society generally. I'm noticing a lot of older people doing very well under the circumstances, making real efforts to accept the situation, to adapt to change quite quickly, and to start to look for things they might do to help society or to help their families or help local neighbourhoods. One of the things I'm also noticing is the number of people who are saying, I'd like to do something, but I don't know what I can do. So it feels to me that we're caught a bit at the moment with quite a cross-section of older people actually wanting to make a contribution, but they're not necessarily being good channels for them to do that. And if we could join those two dots, we have older people not only being at the brunt of this virus crisis, but also being a very much a large part of the solution to it. And that's a very different way for them to be talking about who they are and who they are in society than the way we're currently talking about them in terms of triaging and those sorts of things. So my question, John, is what is it that, is this a moment for older people to galvanise, to be able to make a very significant contribution to society? And this is not even post-COVID, this is right now. And if that is the case, what might it be?
Okay, I mean, I'd like to think so, Mike, but within the confines of social distancing, because these are people who are genuinely at risk. So maybe it's up to us, as Jane was talking about, to invent ways that will allow them to make those contributions. The other thing which we haven't spoken about is people recover. And when they've recovered, we're assuming they have immunity, and then they can do all sorts of things which other people can't. We're not even moving or thinking about that stage yet, but that's certainly something which might be very true for older people. But I see, you know, there are calls for retired nurses and doctors to come back and work for the health system. We're asking people who are at high risk to really potentially sacrifice themselves. That's a major ask. So I think we need to be thinking about the vehicle and the consequences.
Okay, thank you. Bethany Brown.
Thank you, Jane, and thank you to IFA for having this conversation. It's been really fruitful. I am a researcher on older people's human rights at Human Rights Watch, and it's great to have this idea about what are we going to do after the pandemic? How can we use this, or how can we be thinking about society down the line? But I've got to say, I am really thinking about what's happening in the here and now. Human rights, I like to think of human rights as being the standard below which human dignity cannot survive. And human rights are sort of what governs the relationship between individuals and their governments. And the rules that we have in the existing human rights framework are really geared for situations just like this. The rules of this kind of crisis are set out. Governments can take emergency measures to address public health risks, but they have to be proportionate. They have to have an evaluated risk. They have to be applied without discrimination and be a specific length of time. And that application without discrimination, I think, is really at issue. Older people do have the same rights as everyone else. And there have been groups that have been coming out so clearly on this, particularly in the disability movement, sending letters to Tedros from the WHO, sending letters to their national governments about the importance of their own equality, insisting on their own equality. And I think we are very fortunate that many of those groups have also been saying, and based on age, based on disability or based on age, no discrimination can be based exclusively on age or based exclusively on disability. We're fortunate that they're sort of carrying us along in that.
So Bethany, do you have an action
to make sure that that is our message, that older people have the same rights as everyone else? The more we can do in the here and now, because we're seeing it when it comes to triage. We're seeing it when it comes to discriminatory laws that force people to stay in their older people just based on their age, to stay in their homes all the time and not being allowed to leave. We're seeing it in the way that nursing homes choose whether or not any visitors at all are allowed within the facility. We can see it in the delivery of aid in humanitarian situations, and so many more. There are so many experts on the call right now that can share other ways that age discrimination is playing out.
Okay, look, thank you very much for those poignant comments, Bethany. I think perhaps we need another round, another forum to actually pull apart and see if we can actually galvanise some actions. So thank you. Mike Hoden. Hello, Mike Hoden. Okay, John, I'll go back to you and ask you about this question about abuse, because we do have many experts in this field on the call, including Bridget Penhale. So your thoughts?
Well, I think it's a very real challenge that's going to be very exacerbated the longer people are kept together and often in unequal positions of power and control. I think we should, I mean, again, it's another thing which we as a group should be thinking about. Are there things which we can provide which might help reduce the risk? What they are, I don't know, but I think it's likely to be very widespread and very severe.
Look, thank you. And I think that's a real point of action. And it comes back to Bethany's point about human rights and the conversation, but also the actions that the disability sector has put in place. I do want to go to a note from Fiona Mutoni, and she talks about the safety tips that I'm seeing every day. You know, the 20 seconds for washing the hands, etc. And she said, you know, that's with clean water and soap. What kind of advice can you offer older people living in developing countries, in countrysides that don't have clean water and don't have water? What kind of message can we give? Because some of our colleagues, you know, are living in low and middle income countries.
Well, I'd be interested to hear from them.
Okay.
I mean, I think one good thing was the EU announced a very large financial contribution. I think it was close to €1 billion for addressing COVID in low and middle income countries. And I think that's very significant that at the same time that, you know, the rich world is really swamped and struggling, there is a part of them that's still reaching out to try and support their other countries where we know the situation is going to get much worse.
Okay.
And,
so, yes.
Sorry, Jane, it's Kathleen.
Yeah.
I think absolutely the solutions lie in the discussion with those countries and people living in that experience, and also with knowledge about how the virus behaves. So it's broken down quite easily with, you know, with soap and detergents and bleach and alcohol. And so it's thinking about how can we provide those substances, even if it's not using the, you know, the very important resource of water, but what other mechanisms can we provide that will break down that coating around the virus that renders it inactive?
We have it. Thank you, Kathleen. We have a number of people from Help Age International. So if you'd like to raise your hand and if you're able to speak to this issue, because you're really at the coalface. So if you can sort of raise your hand. John, Dr. Mohammed Makhloug from the Alexandra University talks about the high mortality rates in Europe and asks, could it be due to a more virulent strain of the virus than was experienced? You know, we talk about mutations, or is it the fact that this test, isolate, trace was much more effective in certain countries?
Yeah, it's interesting because you see in Germany a high level of cases, but a very low mortality rate. And on the other hand, you see in Italy, very high mortality rate and not so many cases. And I think a lot of it is due to the lack of testing. So we don't know just how widespread the iceberg is in the broader community. Yes, we do get mutations, but the experience from other similar infections is that in that period of time, it would be very rare that the mutation could occur to an extent that would change the outcome of the virus itself.
Right.
It may change a little bit the signature that it has, but it's unlikely to be the cause of those distinctions. I mean, there are other things which we really don't understand. So, for example, why is hypertension? Hypertension is meant to increase the risk, from the evidence from China, to about 6 or 7% a fatality rate in people who are hypertensive. I can't see that can be true, but if it is, why? And people, again, have looked at this, the renin-angiotensin sort of axis and people taking drugs that can modify that axis as part of their antihypertensive regimes. So it may be that there's all sorts of things happening which we don't understand, which make it worse or better, but I don't think it's due to mutations.
Okay, thank you. Just following on from our discussion about abuse, Bridget Penhale has offered some clear actions. And so what I'm going to suggest is that IFA will actually pull out all of these questions and also solutions and good practices, and then feed them back to you as a way of exchanging knowledge. And also, if you've got good practices or lessons learned in your particular environment, can you then forward them, and we will then put them together and disseminate them back out. So Gina, yeah.
Sorry, Jane, I think one of the things I've just managed to get on the chat, and it's really interesting, one of the things that Bridget mentions, which I think ties in with an earlier comment that somebody made, is the idea of scams. And I think as we're exposing people who are less experienced to the internet, we already know that there's a lot of scams that are developing, and I think people who are less experienced are probably going to be more vulnerable to them. So that's one form of abuse we probably can do some concrete things about.
Okay, thank you. Bridget Sleep from HelpAge. Bridget, would you just we'd like to hear your voice, because you've provided some really good links to guidelines.
Hi Jane, yes, we've been developing guidelines around various issues, and we've been doing this based on the kind of the requests from our network members around the world and the issues that they're facing in particular. So I do encourage anyone to have a look at the website, see if what you're looking for is there, and perhaps if it's not, then feel free, please, to get in touch with me, and then we can see if that's something that we can also work with others on to produce guidelines on, because as everyone says, people want sort of hands-on solutions that they can implement right now.
All right, thank you very much. John, before we start wrapping up, I want to ask a question about the importance of older people and those with underlying conditions having vaccinations for influenza and pneumococcal going forward, because what we're experiencing here is health systems which are inadequate, broken, and not coping with what we have now with COVID. And with the flu season coming forward, what are your thoughts about this?
No, absolutely. And I mean, I think particularly even with COVID, the pneumococcal vaccine is very important, because one of the consequences one of the mechanisms for those with adverse consequences is a move through to pneumonia. So yes, it's not just afterwards. We should also be thinking now. I think though, we should be thinking about the whole health system and social care system and how we have underfunded it and let it get to this state where it can't cope with a stress like this. And it's different. This is, again, is probably part of the reason why Germany, the death rates are okay, because their health system has not been underfunded to the same degree as in some other places. So it's not just vaccines, but vaccines are important.
Thank you very much. Look, as we wrap up now, I want to thank everyone that's been on the call. There's about 100 people on the call at the moment, and the areas that we've touched are about human rights, but we also touched on abuse, about resilience and courage, about older people being givers and not only takers. We touched on, the older people in rural and remote areas, but also some of the challenges that older people and populations in general are experiencing in low and middle income countries. We also touched on the virus itself, and the fact that there is something known of it, but there is also a lot that we don't know. We talked about post-COVID and what that's going to look like, and I've decided that there's no normal. There's going to be this new time. And I come back to, something that was also said by Dr. Nabarro, and that is that older people can't be collateral damage in this, that every life has value to preserve and to protect. And while these are sort of aspirational words, that's the only thing that some of us have got to hang on to. We can talk about the practicalities, but some of us are not at that front line. And so the work of IFA and HelpAge and Rights Watch and UN and WHO and experts like John, collectively, it's about where do we collectively work and give voice and action to the next days and weeks to come. I want to acknowledge on the line UN and also WHO. So Mary Manandar, thank you, and also Amal, and I'm sure that there are other members of the UN and WHO community, the academics, the practitioners, older people, industry that's sitting on this line today. So IFA believes that it's about government, non-government, academic, industry and older people that influence and change policy. And so it's our belief that by coming together, talking, sharing knowledge, learning lessons, that we're going to be able to push forward. If you're interested in this kind of series continuing, we're interested in putting it on and we'll get better at it. But I think it's time for us as individuals as well as the international community. So in closing, my last thanks is to the IFA staff. We've been in lockdown now for 3 weeks and we'll be in lockdown for another 12 weeks here in Ontario. And so the staff have worked remotely, productively, with passion and commitment, and some of the time joy. So I thank them for all being on the line today and recognising that their commitment is part of a global commitment. Thank you very much and be well, be safe,